Welcome, knowledge seekers and professionals, to the channel of the Swiss Journal of Radiology and Nuclear Medicine. A quick heads up, the following audio does not include any images, tables, or other additional information. If you're interested in the following paper, please visit our website listed in the caption below. Now, let's get started. Today, we're going to dive into the scientific publication with the title Low Cellular Sclerosis of Anterior Mediastinum. CT-guided biopsy with hydro-dissection of this rare entity case report. Daniela Lavrick, Frank Mosler, Naur Malov, Rua Ben Aid, Gerd Nolge, Andreas Monken, and Jonas C. Abetz. Introduction. Sclerosing mediastinitis was first described by Almont in 1855 and was considered a consequence of syphilis or tuberculosis until 1925, when Knox suggested an association with fungal infections. Sclerosing mediastinitis, also known as fibrosing mediastinitis, is a rare syndrome characterized by an aggressive fibroinflammatory process in the mediastinum. The progressive fibrosis caused by the proliferation of invasive fibrous tissue in the mediastinum often leads to compression and functional impairment of vital mediastinal structures. It has been suggested that mediastinal sclerosis represents the advanced, long-term phase of sclerosing mediastinitis. Given the rarity of sclerosing mediastinitis itself and its association with inflammatory and compressive symptoms in the upper mediastinum, the development of mediastinal sclerosis frequently requires medical intervention. In our specific case, the patient presents with no symptoms and was incidentally diagnosed. Reliable epidemiological statistics are not available due to the low number of cases. As far as is known, it mainly affects young adults and occurs from the first to the seventh decade of life. A sexual, racial, or geographical predilection has not been reliably established so far. Clinical data. 1 history. A 62-year-old female patient who is asymptomatic had an incidental discovery of a periaortic mass in the upper mediastinum during a chest X-ray examination. The subsequently performed CT examination of the thorax with contrast medium revealed the exact positional relationship of the periaortic mass in the upper mediastinum. 2. Laboratory parameters. TBE Eli spot. Negative. Sputum. Direct microscopy. Negative. Antibodies for toxoplasmosis. Negative. Antibodies for histoplasmosis. Negative. Immunoglobulin G. 4 associated laboratory parameters were within normal ranges. Radiological findings. In the chest X-ray overview, in the posterior and lateral projection, as well as in the contrast-enhanced computed tomography of the chest, a periaortic mass is observed in the anterior upper mediastinum without evidence of compression or deviation of vascular structures. There is no evidence of superior vena cava syndrome, which is one of the principal complications of this seldom entity. Procedure. We began by creating a sterile environment at the puncture site and administered local anesthesia. The patient underwent a planning CT scan while lying in supine position. The previously identified periaortic anomaly was clearly visible. We inserted a needle between the sternum and the internal thoracic artery, followed by a smooth hydro-dissection procedure using a 40% glucose solution. While maintaining continuous hydro-dissection, we isolated the lung and carefully advanced the needle into the parapleural mediastinum. Subsequent imaging confirmed that the needle was in an optimal position right in front of the target lesion. We then used an 18G true-cut needle to obtain multiple biopsies, including samples from the periaortic anomaly and the external aortic arch wall. These biopsy samples were preserved in formalin and sent to the Pathology Institute for further analysis. After removing all foreign materials, We applied a sterile adhesive bandage. During the follow-up examination, there were no signs of any primary complications. Procedural strategy. We chose an anterolateral approach that would pass through the lung, but then used a mixture of contrast medium, glucose, and mepivacaine to perform hydro-dissection of the pleura. There are two key points to consider here. If you use plain water or sodium chloride instead of glucose and contrast media, you will only induce a pleural effusion that runs dorsally. Contrast media and glucose, on the other hand, are sticky and remain at the site where you instill them. Glucose in the tissue can be painful. Therefore, we always mix it with a few milliliters of local anesthetic. The further course. The intervention was carried out without any complications, and the patient was discharged without experiencing any issues. However, due to the absence of malignancy in the pathological findings, an additional mediastinoscopy was conducted. As previously mentioned in the patient's medical history, the medical team had reservations about the histologic result obtained from our biopsy and opted to perform a video-assisted thoracoscopy with mediastinoscopy with intubation anesthesia. Once more, no malignancy was detected, and the findings remained consistent. Even a completely resected mediastinal lymph node showed no pathological findings. Histopathological results. Material. Mediastinal CD biopsy assessment. Mediastinal soft tissue with scarce cellularity. No malignancy, especially no lymphoma. Material. Mediastinoscopic biopsy assessment. Inconspicuous mediastinal fat tissue. Sparse cellular sclerosis of the mediastinum. No malignancy, especially no lymphoma. Material. Lymph node region 10 liters assessment. One normal lymph node from region 10 liters. No malignancy, especially no manifestations of lymphoma. Outcome. 4 weeks after the surgical mediastinoscopic intervention, the patient visited our thoracic surgery outpatient clinic for a postoperative evaluation following the so-called video-assisted thoracoscopic surgery. The patient reported feeling generally well and had made satisfactory physical improvement. Both chest X-ray and laboratory results indicated improving postoperative recovery. Oxygen saturation while breathing room air was at 97%, and there was no longer a need for analgesics. As a result, the overall postoperative outcome is favorable. The wound conditions are not causing irritation. Pathological radiological correlation. The histological report revealed low cellular mediastinal sclerosis. The findings are consistent with the images. There is concordance of findings. Nonetheless, we recommend a follow-up assessment. Etiology still unknown. More than 150 years after Aumann's initial description, the causes of mediastinal sclerosis remain largely unclear. While there are several theories and associative approaches, each can only provide a partial explanation. Infections with Aspergillus flavus Anterior have been associated with sclerosing mediastinitis. In the active proliferative phase of IgG4-related sclerosing mediastinitis, there is a notably FDG uptake in PET-CT. Pulmonary hypertension is one of the important complications in patients with sclerosing mediastinitis. From a histological perspective, sclerosing mediastinitis is a rare, benign condition which occurs due to extensive proliferation of a cellular collagen and fibrous tissue within the mediastinum. In the active proliferative phase of IgG4-related sclerosing mediastinitis, there is a notably FDG uptake in PET-CT. Discussion. A CT-guided dorsal biopsy approach in the prone position is viable when the mediastinal mass extends sufficiently into the dorsal regions of the mediastinum. However, in our case, we had no alternative but to approach from the ventral direction. Although rare, Sclerosing mediastinitis can result in extrinsic compression of both mediastinal and neighboring structures, including the cervical carotid artery. This compression, along with its hemodynamic implications, can be effectively addressed through innovative and durable endovascular therapy in the midterm, offering a solution for this uncommon clinical problem. In some cases, sclerosing mediastinitis was discovered with severe bronchial stenosis 1 year after external thoracic radiotherapy. In histopathological exams, often there are dense bundles and sheets of hyalinized collagen, accompanied by a relatively sparse inflammatory infiltrate, serving as microscopic indicators of the disease. There are 3 different stages classified based on the ratio of fibrous tissue to the inflammatory component. The differential diagnosis for sclerosing mediastinitis encompasses intrathoracic desmoid tumors, solitary fibrous tumors, desmoplastic mesothelioma, and inflammatory myofibroblastic tumors. Most authors recommend conducting immunohistochemical examinations and/or measuring serum IgG4 concentrations to exclude the possibility of IgG4-related fibrosis. If the underlying cause of sclerosing mediastinitis is indeed IgG4-related, surgical resection may not be necessary for curing the disease. The mechanism by which tamoxifen operates in these sclerosing mediastinitis conditions remains uncertain. Tamoxifen is most widely recognized for its role as a partial agonist at the estrogen receptor. Fibroblasts express these receptors, and in approximately 1/3 of cases, they can be observed in desmoid tumors and desmoid-like lesions, where they manifest as proliferations of fibroblasts. A case of intrathoracic sclerosing mediastinitis, which resulted in a mass that resembled lymphoma, is reported in connection with long-term propranolol therapy. Antifungal and antituberculous agents have been recommended for cases showing evidence of active granulomas. However, these, along with steroids, are typically ineffective in established cases with extensive fibrosis. Most reports highlight the benign nature of the condition and recommend minimal intervention unless symptoms become life-threatening. Conclusions: sclerosing mediastinitis can manifest as a mass lesion in the anterior upper mediastinum, requiring differentiation from other mass-forming sclerosing conditions like nodular sclerosis, Hodgkin's lymphoma, sclerotic mesothelioma, oligometastatic phenomena, and desmoplastic carcinomas. Therefore, the significance of an early microinvasive biopsy cannot be overstated, as it is crucial for reaching a diagnosis and determining the histologic subtype of sclerosis, enabling the initiation of appropriate treatment. This case highlights possibility of rare presentations of rare diseases in rare sites, which need to be approached with high index of suspicion in an endeavor to achieve an early tissue diagnosis for effective management and favorable outcome. We have come to an end. Thank you for listening in, and until very soon with more interesting publications. If you want to share your own paper in our journal, feel free to contact our team. We are looking forward to hearing from you. Don't forget to like and share if you enjoyed this content. Click the subscribe button so that you don't miss out on future publications from the Swiss Journal of Radiology and Nuclear Medicine. Until next time.